Someone asked me to go over RSI medications, and so I thought for our tip of the week, we could do just that. Also, this PDF was taken from my ICU Crash Course revamp that is launching on October 11th, so stay tuned. Couple of things before we go over these medications specifically. When you are intubating someone and performing RSI, which is rapid sequence intubation, the goal is to get your patient sleepy enough, quickly enough in order to intubate them rapidly. But there are a lot of different types of sedation medications that you can use on patients. And luckily, being an ICU nurse, I don't really have to pick which of those medications are given to the patients. That is up to the provider. But it is important to have a general idea of how these medications work and what types of patients we want to use them on, as well as side effects. So that way you're prepared to help manage this patient. Also, we want to make sure that we are sedating our patients before we paralyze them. You may have heard the term thrown out there, we want to date before we rock, or we want to date before we suck. And so the whole point is make sure you sedate your patient before you paralyze them. Starting off, we have ketamine, has a very quick onset, doesn't last too long, and we use this a lot in patients that are hemodynamically unstable, as well as asthmatic patients. And that is because ketamine is a bronchodilator. Typically, when you give ketamine, you may see Versed also given with it as sort of an adjunct. Etomidate is a medication that I see a lot, and I have heard mixed opinions on etomidate, but it is still out there and it's still used a lot. It has a minimal effects on hemodynamics, so this is a great medication in patients that may not be super stable. But there is no analgesic effect, and so you want to also make sure you're administering pain medication like fentanyl with it. Propofol is that white medication that you see, the Michael Jackson juice. It works very quick. It also wears off very quick. It's good for your patients that are in status epilepticus because it also has anti-seizure properties. However, it causes cardiac depression, so hypotension, myocardial depression. So prepare for patients that are getting propofol to see a significant drop in their blood pressure. Versed and fentanyl. So Versed is a benzo, and it also works very quickly and wears off pretty quickly. And typically we'll combine it with fentanyl. So we don't just usually give Versed by itself. And these two medications are typically given in your patients that are already pretty obtunded or stuporous prior to intubation. We just want to give them something to make sure that they are as comfortable as they can be since they can't communicate with us. It can cause hypotension and respiratory depression if the patient gets a really, really high dose. Fentanyl is your pain medication, very, very rapid onset, wears off very quickly as well. And this should be given with another induction agent. We never typically just give fentanyl by itself. And it can cause hypotension and bradycardia, especially in higher doses. I also want to cover your paralytics. Succinylcholine is the quickest acting paralytic that we most commonly use, and it only has a duration of 6 to 10 minutes, but is not good for hyperkalemic patients because it can push potassium into the serum. So if you have a patient that already has an elevated potassium and you give them succinylcholine, then you could potentially give them an even higher potassium, which then you have all the negative side effects of hyperkalemia. Rocuronium and vecuronium, these both have longer duration. So if you are giving one of these paralytics, you need to give your patient some sort of sedation after, I'm just not talking about the regular RSI sedation, in order to make sure they don't wake up on the ventilator. So let's say you gave your patient etomidate, some fentanyl, and now you just gave them vecuronium, then you're going to need to start your propofol drip or whatever drip, or give some more pushes of medications after you get the patient intubated, because most likely your patient is going to wake up and they're going to be pissed. Just a couple helpful reminders. Make sure you ask the provider ahead of time which medications they want, especially if you have the time to set everything up, draw everything up. I always like to grab extra of the medication doses to make sure that in case the provider is like, oh, that 50 of fentanyl is not enough, give another 50, I'm ready to go. And then as always, hypotension, very common when we are doing RSI, so be prepared with a fluid or pressor in order to support that patient's blood pressure. And that's your tip of the week. And make sure you stay tuned. October 11th, I am launching my ICU Crash Course revamp.